This is Maritza Munoz, and the monograph that I chose is over deep vein thrombosis. I chose this topic because I don't really know much about DVT, and when I saw this during clinical, it was interesting to see how it was being treated. I wanted to learn more about DVT and decided to do my monograph over it. The patient I cared for was a 99-year-old female. She came in for acute blood loss, anemia, painless rectal bleeding, increased weakness, and a DVT in the right leg. Her hemoglobin was 7.8, hematocrit 24, RBCs 2.51, and potassium 3.4. She was in normal sinus rhythm in the 70s, with diastolic blood pressures in the 40s. She had normal saline running at 75 milliliters per hour, and she also had an IVC filter. Some of the medications the patient was taking were Xarelto, Plavix, and aspirin. Xarelto is an anticoagulant that prevents DVT. Plavix is an antiplatelet blood clotting prevention drug, and aspirin is a low-dose blood thinner. Venous thromboembolism is the overall term to describe blood clots that develop in a vein. There are two types of VTE, DVT and pulmonary embolus. Virchow triad is the primary theory of DVT pathophysiology and references the three groups of factors that contribute to DVT development. Virchow triad consists of vascular or endothelial injury, alterations in blood flow such as in venous stasis, and alterations in the coagulation or constituency of blood. Changes or damage to the venous wall can occur as a result of inflammation, such as in sepsis, vasculitis, or traumatic injury. Alterations in blood flow can occur because of venous stasis, such as from prolonged immobility, dehydration or shock states, increased age, and obesity. Constituency of blood can occur as a result of pregnancy, inherited coagulopathies, such as thrombophilia, and as a side effect of certain malignancies, such as cancer, or pharmacologic agents. These factors contribute to the formation of procoagulants, as well as to the detriment of anticoagulants, leading to increased risk of clot formation. While venous stasis is the most impactful of the three factors, research has shown that venous stasis alone typically does not cause DVT. However, when combined with vascular injury or inflammation, such as in cancer or after surgery, the risk of DVT sharply increases. If left untreated, a DVT can break off from where it is lodged in the lower extremity and travel through the vascular system into the lungs, where it can become a pulmonary embolism. Traditional care of the patient with DVT is focused on eliminating the components of Virchow triad by increasing mobility as appropriate, increasing blood flow, and preventing stasis, primarily with compression garments and anticoagulant therapy, and preventing venous wall damage. Prevention of DVT is a key component of treatment and includes a risk assessment early in admission, as well as clinically appropriate prophylaxis, such as compression stockings. Accurately assessing and identifying patients at risk for DVT and collaborating with the medical team to provide optimal preventative and management interventions to patients is critical for the nurse. Despite the available evidence about prevention, many hospitalized patients still do not receive preventive care and develop DVTs that then have to be managed more aggressively and potentially on a longer-term basis. For acutely ill hospitalized patients who are at an increased risk for DVT, anticoagulant thromboprophylaxis with low molecular weight heparin should be initiated. Prophylaxis should not be extended beyond the hospital stay or the period of immobilization. Mechanical prophylaxis should be used in place of pharmacological agents if the patient is at an increased risk for bleeding, at least until the bleeding risk subsides. Patients at low risk for VTE should not receive prophylaxis. For critically ill hospitalized patients, low molecular weight heparin should be initiated unless the patient is at a high risk for bleeding. If this is the case, mechanical prophylaxis should be initiated until the risk for bleeding decreases, at which point pharmacological prophylaxis should be initiated. The first article that I chose is a level of evidence 1, which means evidence from a systematic review or meta-analysis of all relevant randomized controlled trials or evidence-based clinical practice guidelines based on systematic reviews. The findings were that patient adherence was higher among patients with knee-length versus thigh-length compression stockings. Across all studies, patients reported not wearing stockings due to discomfort or need to remove the stockings for ambulation or bathing. Notably, a 2011 study found that 74% of patients with knee-length compression stockings were incorrectly sized. Implementation of an intervention reduced this to 34%. Across all studies, knee-length stockings were reported to be more comfortable than thigh-length stockings were. This article relates to my patient because she was being discharged with knee-length compression stockings. The second article I chose was pharmacologic versus mechanical prophylaxis. It is also a level of evidence 1, and the findings for this showed in total 4.1% of patients receiving IPC alone experienced a DVT compared to 2.19% of patients receiving combined prophylaxis. No differences were found between surgery subgroups. Moderate quality evidence suggests that combined prophylaxis may lower rates of DVT in comparison to IPC alone. In clinical, my patient was receiving IPC and also medications, and the medications that she was taking was Xarelto, Plavix, and aspirin. Some nursing recommendations for assessment are to determine the risk status for DVT development beginning on admission and at each transition of care. Also assess for history of clotting disorders such as previous DVT. For data analysis, you want to monitor platelet count, bleeding time, INR, and APTT, and also monitor D-dimer results. Under planning and implementation, you want to apply compression stockings as prescribed, administer subcutaneous heparin, and monitor for signs of respiratory distress. For discharge planning, you want to assess the patient's or family member's ability to perform self-injections if low molecular weight heparin is to be administered. You want to ensure that the patient has a plan to acquire prescribed medication and therapeutic equipment and supplies after discharge. For evaluation, the patient will experience no signs of DVT development or recurrent VTE, and the patient will experience minimal to no pain in the affected extremity. Combined prophylaxis was used to treat DVT in my patient. The medications used were Xarelto, Plavix, and aspirin. The patient was also using ICP, which is intermittent pneumatic compression. Since the patient had a DVT, the goal was to prevent new clots from forming. Ambulation was also encouraged by my nurse, and she would check on the patient frequently to make sure she was ambulating. The monograph helped improve my care by knowing what signs and symptoms to look out for, how to prevent further complications such as pulmonary embolism. In addition, it provided information on what labs to monitor, and in my patient, the provider wanted to monitor her hemoglobin. In conclusion, the preferred treatment for DVT is combined prophylaxis of medication and ICP. Patients being discharged with knee-length compression stockings will most likely wear them as ordered. In DVT, prevention is the main priority.